cordially welcome you all. And आज का सेशन बहुत ही इंटरेस्टिंग होने वाला है. हम जैसे कि हमने देखा कि पिछले सेशन में हमें बहुत कुछ सीखने को मिला था. पर बिफोर दैट मैं अपने पैनल मेंबर्स को आपको इंट्रोड्यूस कराना चाहूंगी. दिस इज डॉक्टर ज्योति फ्रॉम शेयर इंडिया, who's the chief coordinator for this e-NISCHIT, and we have also Mr. Rakesh from Share India, who helps us with the logistic and IT part. So I welcome you all. I'm Dr. Ananya, chest specialist at NITRD. तो आज का सेशन जैसे कि हमने पिछली बार देखा, बहुत ही इंटरेस्टिंग और बहुत ही इम्पोर्टेंट टॉपिक जिसके बारे में हम लोगों को ज्यादा नॉलेज नहीं है, उसके ऊपर बेस्ड है, एंड दैट इज ऑप्थाल HIV केस. सो वी आर वेरी ग्रेटफुल टू आवर केस प्रेजेंटर डॉक्टर धर्मपाल, जो कि हमेशा ही हमारे लिए बहुत अच्छे केसेस, हु ऑलवेज ब्रिंग्स आउट एंड फिशेस आउट द बेस्ट ऑफ केसेस, एंड he brought up this case for us so that we could discuss such an important and pertinent topic in our session. And because we don't have much knowledge about opthal HIV as a general physician or as a ART medical officer. So I welcome you, Dr. Dharmapal, and I thank you for sharing your case, such an excellent case, so that we can have a good discussion. Welcome, sir. तो आज हमारे जो एक्सपर्ट हैं वो बहुत ही सीनियर चेस्ट कंसल्टेंट एंड एकेडमिक इंचार्ज सीनियर ऑप्थल्मोलॉजिस्ट हैं DDU हॉस्पिटल से, डॉक्टर जतिंदर सिंह भल्ला. बहुत ही एमिनेंट ऑप्थल्मोलॉजी. वी आर वेरी ग्लैड एंड वी आर वेरी प्रिविलेज्ड वी हैव him on board. So Dr. Jatinder Singh Bhalla is a consultant and academic in charge Department of Ophthalmology, DDU Hospital, New Delhi. He's also the secretary DOS, that is Delhi Ophthalmological Society, and he's member scientific community AIOS. So sir has bagged many awards, many presentations, and he has innumerable papers in peer-reviewed national and international journals. He has also been awarded Eminent Teachers Awards and Krishna Singh Sohan Trophy for Best Clinical Paper. So we are actually very, very fortunate to have him on board. And उनसे जैसे कि हमने पिछली बार देखा, तो एक केस जो कि हमारा रीजन फॉर डिस्कशन ही कंफ्यूजन था, उसमें बहुत हमें क्लैरिटी मिली थी. सो वी आर वेरी प्रिविलेज्ड वी हैव हिम ऑन बोर्ड, एंड वी कैन स्टार्ट विद द केस प्रेजेंटेशन. So Dr. Dharmapal?
Yes, madam.
Yes, we can start with the case presentation. Thank you, sir, for joining.
This is the case of a female patient, aged about 43 years, and weight is 35 kg at the time of admission. Now the patient's weight is increased up to 55 kg. Actually, this is a case of conundrum, that is means confusion and problem that is difficult to solve. That is means the patient actually came with tuberculosis to us, and then we admitted the patient and tested for that and also treated. But yearly date of ART registration is 4821 and the date of ART registration is 2921. Date of TB confirmation is 4821. The date of ATT initiation is 4821. Pulmonary TB. And the date of IPT completion is 2811 to 2022. And the patient of the fastest is TBS. Other details: the patient mother and father were HIV positive. Patients have died. Patient husband is also positive, went away, and the patient is also positive, having 2 children, 1 male and 1 female. Both are negative, staying at Hyderabad as per the client information. The patient is at the age of 42 years, had come to general medicine for diarrhea, fever, headache, and showed to the physician take treatment for 15 days. After some time, the patient has got fever and blurring of eyes, treated by the local RMP, and left the left eye sight is diminished after from eye drops. And later they went to AIOS hospital at Mangalagiri, where the treatment for ophthalmology, and the patient also having rash at that time, and referred to dermatology department and diagnosed as HIV positive, referred to NRI hospital for ART treatment. After registration, suspected TB clinically and referred for CB0, where they diagnosed as TB, and anti-TB treatment started along with ART and TND, lamivudine and dolutegravir. So the patient had taken treatment history of ganciclovir injections at private hospital Guntur. Later they referred to Prasadai hospital and ruled out the CMV, and then the patient went to Aravind hospital Madurai, where they diagnosed B, HIV, occlusive vasculitis. The CD4 count at the ART station is 487. Serial CD4 counts are 1. Is 157. Number 2 is 33418. And CD4 now is 688. And the patient increase well-being is also very better. Viral load, if available, is for TND from the beginning. And 3 also, we have done 3 times. And that our target not detected 3 times also. Date is 2/8/22. And the serum creatinine is 0.6 milligrams per dilution. Total bilirubin is 0.4 milligrams, and AST 149 upper limits, and 387 1U. And the serum of KFT is urea 14, and creatinine is 1.5. And the hemoglobin is 7.9 grams. WBC count is 5,300 cells per cubic millimeter. Platelet count is 2.4 lakhs per this one. Neutrophil 48%, lymphocyte 40%, eosinophils 0.8%. 8%, sorry, is 8%, and monocytes 0.4%. Glucose randomly we have tested 79 milligrams per dilution, and the CV0 is positive, and X-ray test is a normal study. Ultrasonography is mild hepatomegaly, and ART regimen is TND, and ATT regimen is 4 FDC 2 pills per day for 2 months, and 3 FDC given. IPT also given. CPT is 1 OD. Other medicines are E tablet CVA, tablet metop, 5 drops, 1 ID drops, and augmentin 625 milligrams, Rantac 150 milligrams, PCM 500 milligrams, tablet multivitamin is also given, and tablets, because at the time of the treatment, along with the TLD, we have added more altogether once again 50 milligrams. Diagnosed. The case issues for discussion is diagnosed is the HIV occlusive vasculitis, uveitis is due to not taking treatment ART for HIV. Is due to TB granuloma causing uveitis. Is due to occlusive vasculitis of any allergic phenomena of using any other drugs previously. This is the 3 questions were posed in front of us for before treatment, and afterwards also we are in confusion whether the question mark. So what is it? Easy to do to tuberculosis. In short. Thank you, madam.
Thank you, sir. It's as Dr. Dharmapal has done the case summary very nicely, yeah, and told us about this case, which was a 42-year female who came with complaints of diarrhea and showed to the physician fever, headache. So eventually, she was diagnosed tuberculosis and started on tuberculosis treatment. And when she had eye symptoms, she was referred, and it was picked up that she has HIV also. So that treatment was started, but the main confusion and the main issue of discussion in this case is that the eye diagnosis, or whatever pathology she had in eye, it was still question mark whether we were right on our diagnosis, whether we were right on our management. And sitting at ART medical ART staff as ART staff, जैसे ART staff हम बैठे हैं, तो हमें क्या क्या पॉसिबिलिटी हम सोच सकते हैं, कब हमें अलर्ट होना है. तो आज के इस डायरेक्टिक डिस्कशन से हमको यही सब सीखने को मिलेगा. आज हमारे we have a privilege that Dr. Jatinder Singh Bhalla is joining us, who is a very senior and eminent ophthalmologist. And आप खुद समझेंगे कि जैसे by the end of the didactic आपको कितना चीजें clear और crystal clear हो जाएंगी. And that's all because of the expertise he carries, and we are very grateful for him to be joining us today. Thank you, sir. Thank you for joining the session today and accepting our invite as an expert.
Yeah, once again, I'm thankful to the team NISCHIT, Dr. Jyoti Sharma, Dr. Ananya, and Dr. Upasna for giving me this opportunity to participate in this national initiative to strengthen collaboration between HIV-TB through e-learning. So we start with this case, which is very rightfully titled as Conundrum. The patient in the question is a 43-year-old female whose mother and father died because of HIV, and husband was also found to be HIV positive. 2 children were HIV negative. Patient was diagnosed to be having pulmonary tuberculosis by CBNAT on 4th August 21, and anti-TB treatment was promptly started on the same date. ART treatment was started on 2nd September 21. CD4 counts initially must have been low, but after starting ART treatment, we found that the CD4 count started rising. And on January 22, 6 January 22, they were above 100. On March 22, they were above 400. And on 12th August 22, they were above 680. On 11 June 21, as pointed out by Dr. Dharmapal, that the patient went to AIMS Guntur, where the patient was found to be having on ophthalmological examination, was found to be having in both eyes cytomegalovirus retinitis. Anterior segment had acute anterior uveitis. And for the sake of all of you, I'll tell you what uveitis is. Uveitis is inflammation of the iris, the uveal part of the eye. That is, uveal part is iris, ciliary body, and choroid. And anterior uveitis is only the front portion, that is, iris is inflamed. And so there is manifestation of acute anterior uveitis, which the patient usually complains is dull aching pain. There is redness, which is in the form of circumcorneal congestion. And in the anterior chamber, you find aqueous flare, cells are there, and anterior synechia, that is adhesion between the iris and the lens can occur. So the patient was given intravitreal injections for both eye CMV retinitis, and the first injection in left eye was given on 11 June 21. It was repeated in December 21, whereas right eye received just one injection of ganciclovir 11 June 21, and then after 6 months, that is in December 21, patient was also started on TAP valganciclovir for both eye CMV retinitis. As pointed out in the present case is, there are some issues for discussion. The patient was diagnosed to be having both eye HIV as causative to cause occlusive vasculitis. And so the question in the present discussion is the uveitis or vasculitis due to not taking treatment for ART for HIV, or is it due to tuberculosis? Or the question is whether both HIV and TB are not responsible, but the occlusive vasculitis in the retina of this patient is due to allergic phenomena or drug-induced toxicity. So let's go to the case records one by one. The diagnosis of HIV occlusive vasculitis or CMV retinitis is not only based on the clinical manifestation, the fundus picture, fundus presentation, but also we have to objectively demonstrate the organisms. So the vitreous aspirate was done on February 22, and it was subjected to PCR test, and it was found to be negative for all the organisms like Mycobacterium tuberculosis, varicella zoster, herpes simplex, and cytomegalovirus. So there was no objective demonstration of any of these organisms. This is the fundus picture which has been taken by another eye hospital in Guntur, and you find if you see all these retina pictures, you find it is very hazy. Nothing is clear. Why it is not clear? Because there is inflammation in the vitreous, so vitritis is present. This is the optic disc which is faintly seen, and these are some yellowish white patches present in the mid periphery of the retina, and rest of the details are not clear, except I find there are some amount of hemorrhages inferior to the disc in both eyes, and so the clinical diagnosis of cytomegalovirus retinitis both eye was made. This is the discharge summary of the patient, where again you find that the media shows vitreous haze, there is sheathing of the vessels of the retina, and you find that retinal edema is present. And for the diagnosis, clinical diagnosis of CMV retinitis, patient was given injection, intravitreal injection of ganciclovir. And this is the discharge summary again, where it shows that the patient is on ATT and also on valganciclovir, besides receiving intravitreal injections of ganciclovir. This is the case record from AIMS Guntur, where they have drawn the fundus picture and they have demonstrated these are the hemorrhages, these are some exudates, and there is also, this is the macula, which is the most delicate seeing portion of the eye retina, which it shows macular edema. This again shows that the patient has received tablet valganciclovir orally and intravitreal ganciclovir. These are again the same documents. And what I was telling you in the form of anterior uveitis, this is just for your telling you how anterior uveitis looks like. This is the section of the cornea. You find on the back of the cornea there, these are white cells, which is called keratitic precipitates. And in the space between the iris and the cornea, you find that the aqueous normally is transparent. There is nothing there, and it is optically empty, but here you find some cells are there, and these are the adhesions of the iris with the lens, which is causing the synechiae formation. So the differential diagnosis on the basis of this, that is the patient is having anterior uveitis and his patient is also having both eyes retinitis. Although I do not agree with the diagnosis of CMV retinitis for reasons which I'll stress in the subsequent slides. So the differential diagnosis on the basis of these picture is either HIV occlusive vasculitis, uveitis, CMV retinitis, or it is tuberculosis as the cause, or it is once the heart treatment has been started, then the CD4 cell count starts recovering above 100, 200, then the patient may develop what is called immune-related uveitis, which is part of immune reconstitution inflammatory syndrome, or the patient has developed acute retinal necrosis as immune reconstitution inflammatory syndrome in HIV. So it may be HIV may be the causative organism, CMV may be the causative thing, or tuberculosis, or it is IRU, which is manifesting as acute retinal necrosis. So what happens if we go by the CD4 count? What are the different ophthalmological manifestations? If the CD4 count is less than 500, you get herpes zoster ophthalmicus. Less than 200, you get tuberculosis and pneumocystis. If less than 100, you get either toxoplasma retinitis or progressive outer retinal necrosis, which is different from acute retinal necrosis, or cryptococcal choroiditis. And if it is less than 50, straight away we get CMV retinitis. So the most common ocular complication of HIV is called HIV occlusive vasculitis, and it occurs in 50% of the patient when the CD4 count is less than 100. And how does it manifest in the retina? You find that there are multiple cotton wool spots, and there are also these are red things are called hemorrhages. These are flame-shaped hemorrhages, so they are called superficial hemorrhages in the nerve fiber layer. And what is the etiology? HIV infection of the endothelium of the retinal microvasculature, plus there is deposition of the circulating immune complexes. But mind you, it does not affect vision to a degree that is noticed by the patient. And you get in the retina, which I showed in the previous slide, cotton wool spots plus hemorrhages. But this may be confusing, as you get same hemorrhages and cotton wool spots in other occlusive conditions of conditions of the retina, which may be even hypertension and diabetes. But now we have this patient which is HIV positive with CD4 count less than 50 cells. So what is pathophysiology? CMV reaches the retina hematogenously, infects the vascular endothelium, causes vascular endothelitis, plus immune complex deposition on the endothelium of the cells. Then it spreads to the retina cells, and then impaired CD4 cell function permits uncontrolled CMV replication. How does it manifest in the retina? It gets like you have these yellowish white patches, and there is periphlebitis. You find this is the retinal vein, and there is sheathing of the vessels, but there is absence of significant vitreous inflammation, vitritis. But if you go back to the previous slides of the fundus picture shown at AIIMS Guntur, we found that the patient was having significant vitreous haze, vitritis. So I differ with the diagnosis of CMV retinitis in our patient. In contrast, toxoplasmosis and tuberculosis can cause significant vitritis. So CMV retinitis tend to occur in patients whose immune system is significantly suppressed. Typically occurs when CD4 count is less than 50, and rarely the CD4 count is more than 100 cells. So before the widespread use of HART, CMV retinitis was noticed in 7 to 40% of the patients. But now with starting HART, this has come down by almost 80%. So CMV retinitis begins as a small white retinal infiltrates, and which if seen may resemble a large cotton wool spot. There is perivascular fluffiness, and then it can later on have central clearing. So diagnosis is largely based on the classical retinal findings, which I've shown earlier. And then there is objective analysis by PCR analysis of the vitreous or aqueous aspirates supports the diagnosis. In our case, PCR analysis of the vitreous did not support the diagnosis. So these are the three ophthalmic manifestations. One is acute retinal necrosis, or there can be progressive outer retinal necrosis or CMV retinitis. You find immune status in acute retinal necrosis is rarely immunosuppressed, in contrast to the progressive outer retinal necrosis and CMV retinitis, which occurs in immunosuppressed patient. Vitreous reaction, there is significant vitritis in acute retinal necrosis and CMV retinitis, but it is not that much in progressive outer retinal necrosis. Retinal hemorrhages are uncommon in progressive outer retinal necrosis, whereas our patient also had cotton wool spots and significant hemorrhages. So acute retinal necrosis, there is rapid response to treatment. There is occlusive arterial vasculitis, and it can also cause, later on, lead to optic atrophy. And if you compare progressive outer retinal necrosis with CMV retinitis, you find that progressive outer retinal necrosis progresses very rapidly. There is no vascular inflammation. So CMV retinitis can be either fulminant, granular, or perivascular. What is fulminant? You have hemorrhagic necrosis. Granular is when it is found in the retinal periphery with no necrosis. And perivascular is there is sheathing of the veins. So this is on the right side, upper side is this is the fulminant variety. This is the granular variety. And here you find these are the vessels which show sheathing. This is the frosted angiitis pattern. So this is fulminant, granular, and frosted angiitis pattern. Depending on which part of the retina it is involved, zone 1 is a very delicate portion because this affects the macula. The visual symptoms, visual impairment will be marked. In contrast, if it is in the zone 2 or zone 3, where the visual symptoms may not be there and it may be detected on routine ophthalmic screening. So the patient may be asymptomatic depending on where the retinal lesions are, but usually the patient complains of floaters, flashes, blind spots, pain, photophobia, and diminution of the vision. So the treatment modalities, oral ganciclovir, intravitreal ganciclovir, given for some duration of the treatment. Mind you, CMV retinitis that involves more than 25% of the retina will lead to retinal detachment. Prognosis becomes very poor. But prognosis has improved significantly after the advent of heart. But even with heart and anti-CMV therapy, mortality is still high in these patients who develop CMV retinitis. So therefore, it makes clinical sense to screen all patients who are at risk when the CD4 count is less than 50 cells. And we have to not only do the one examination, we have to repeat this ophthalmic screening every 3 months. So now let's come to the second question in our differential diagnosis is HIV was not the cause, tuberculosis is the cause. Tuberculosis causes a hypersensitivity response, and very rarely it is due to the direct infection. So what are the clinical signs that this is TB uveitis and TB anterior uveitis or choroiditis? We find cellular reaction in the anterior chamber, which I showed you in my initial slides. There is vitreous opacities, there is perivascular sheathing, and ocular investigations are done. We have to demonstrate of AFV from the vitreous or aqueous aspirates, positive PCR reactions from aqueous or vitreous aspirate. Then the systemic investigation has to support us, like positive Montu reaction, then evidence of extrapulmonary tuberculosis, and then therapeutic response to ATT over a period of 1 month. So depending on that, we say whether it is a confirmed intraocular TB, probable intraocular TB, or possible intraocular TB, depending on these criteria, which has been given by the Sun classification. What happens if patient has both HIV and TB? You will find that the classical lesion in these patients is choroidal granuloma, and the vitreous inflammation which is there, if there is only TB choroiditis, will be lacking if there is HIV and intraocular tuberculosis because of suppression of the inflammation. And so these are the recommendations for timing of ART. Whenever patients have both tuberculosis and HIV causing ocular manifestation, we have to give ATT first, followed by ART within first 8 weeks, that is within 2 months. So ATT first and ART later on. And what happens if the patient is acute retinal necrosis, which may be a possibility in our patient because the patient has very little vitreous inflammation. Here we don't give ganciclovir or van ganciclovir orally. What we do is the standard care of the treatment is intravenous acyclovir or oral valacyclovir. So treatment is different of acute retinal necrosis as compared to the CMV retinitis. And what happens? This really confounds and confuses the picture. You have started the patient on heart treatment. CD4 cell count starts rising, and within 2 months of starting heart, patient develops immune reconstitution inflammatory syndrome or immune recovery uveitis. And what are the diagnostic criteria that this patient is not CMV retinitis, not acute retinal necrosis? It is just iris. That is, patient should be HIV positive, patient should be receiving heart, there is increased inflammation in the vitreous and aqueous, there is temporal association between immune reconstitution inflammatory syndrome and initiation of heart, usually of the 2 months, and the clinical course is not consistent with drugs toxicity. So these are the, again, I'll repeat, when we started the presentation, we were confused whether the HIV is the causative organism or tuberculosis is the causative organism, and the patient developed occlusive vasculitis due to not starting ART. No, patient was promptly started on ART. TB is not the cause because TB, there is no choroiditis, and we have significant vitreous inflammation. And allergic phenomena, yes, it may be true in the form of immune recovery uveitis. So what is the standard protocol? Start the patient, if having both TB and HIV, start the patient on ATT. After that, start the patient, treat fully CMV retinitis by giving intravitreal ganciclovir and oral van ganciclovir. Only when you find that CMV retinitis has totally resolved, that is, there's an improvement in retinitis, decrease in vasculitis, decrease in inflammation in the anterior chamber cells, only then start heart treatment, or not when the CMV retinitis has not improved. And when you start heart treatment, we have to give aggressive anti-CMV treatment before and after starting heart. So the sequence of events should be ATT, treatment of CMV retinitis number 2, and then heart treatment number 3. So CMV retinitis may be asymptomatic. Patient with very low CD4 counts are advised to have regular ophthalmological checkups. Heart has increased survival rates, improved quality of life, but it may lead to, in some patients, when the CD4 count starts increasing above 50 and 100, it may lead to immune reconstitution inflammatory syndrome, and ocular iris leads to worsening of the clinical manifestation, which is indeed a paradoxical reaction. And it has been found that in large retrospective study from India, ocular iris was seen in 17% of the patients on heart, and treatment is mostly aimed at controlling the inflammation in these iris by topical systemic corticosteroids and along with the heart treatment. So what I want to say is that although the patient was seen at AIMS Guntur and also at another hospital in Guntur, Sudarshani Eye Hospital, and was empirically started on the treatment for CMV retinitis, but the biggest point which goes against the diagnosis of CMV retinitis is in significant vitreous haze, which does not occur in CMV retinitis. Well, so what I tend to follow in this patient is probably when the patient was not adequately treated for CMV retinitis, and before the CMV retinitis resolved, the patient was started on heart treatment, and with heart treatment, CD4 cell count started rising, and patient in turn developed what is known as IRIS, that is inflammatory immune reconstitution inflammatory syndrome. So that is the reason the patient did not improve as far as the vision part and the retinitis part was concerned. So in this patient, I tend to differ. The patient should have been started for, along with heart, systemic steroid and topical steroid, and that is probably the reason. Same way, although the patient showed improvement in the anterior uveitis part, because there the patient was given the standard treatment for anterior uveitis in the form of topical steroid, topical cycloplegic, atropine ointment, homatropine drops. But the posterior, that is the retinal part, did not show significant improvement as was expected in these patients. So with that, I come to the end of the presentation. Thank you for your kind, patient, and attentive hearing. If there are any questions, I'll be too glad to answer.
Yes, thank you, sir. Thank you for your excellent didactic. And thank you, sir, for telling us कि इतनी जो differential diagnosis के बारे में डिटेल से, ताकि वो eyes don't see what mind doesn't know वाली situation होती है, तो हम जो ART medical officers हैं और जो staff हैं उनको समझ आएगा, क्योंकि बहुत paradigm change हो गया है. We have AIDS patient with better immunity now, so I'm sure ये पूरी एपिडेमोलॉजी ही चेंज हो रही है. वी हैव मच मोर प्रिजर्व्ड इम्यूनिटी. पहले तो बिल्कुल इम्यून सप्रेस्ड होते थे, तो ऑब्वियसली सीएमवी वाज लाइक स्पाइनल रिफ्लेक्स आंसर की वही होगा. So that's a big point. अब तो they are like more than 400, more than 500 CD4 counts. So immunity is well preserved. So we have to now open our eyes to other differential diagnoses only also, and not get biased by immune suppression. So thank you so much, sir. So we'll now do the post-test poll, and please, any questions, please feel free to ask. It's a great opportunity to interact. Dr. Jyoti, आप post-test poll बता दीजिए.
जी मैम. तो हमारा पहला क्वेश्चन था, CMV रेटिनाइटिस पेशेंट्स में कैसे हाउ इट इज अकर इन पेशेंट विद HIV इन्फेक्शन. जब HIV इन्फेक्शन होता है तो CMV रेटिनाइटिस कैसे आती है. तो उसके ऑप्शन है, ए ऑप्शन था जब CD4 काउंट आपका 100 या उससे ज्यादा हो, CD4 काउंट आपका 50 से कम हो, CD4 काउंट आपका 50 और 100 के बीच में हो, या ऑप्शन डी है कि CD4 काउंट आपका 200 से ज्यादा हो. तो इसका करेक्ट आंसर है ऑप्शन बी, जब CD4 काउंट आपका 50 से कम होता है उस समय पे CMV रेटिनाइटिस की टिपिकल अपीयरेंस इट इज मोस्ट लाइकली टू अकर. क्वेश्चन 2 है हमारा, हाउ डज CMV रेटिनाइटिस टिपिकली अपीयर इनिशियली इन द रेटिना. रेटिना में वो शुरू में कैसे दिखता है, कैसे अपीयर होता है CMV रेटिनाइटिस. इसके ऑप्शंस हैं, लार्ज कॉटन वूल स्पॉट्स की तरह दिखता है. ऑप्शन बी, पेरीवैस्कुलर फ्लफी वाइट लीजन्स के जैसे दिखता है. ऑप्शन सी, ग्रैनुलर अपीयरिंग लीजन्स विद सेंट्रल क्लियरिंग. ऑप्शन डी, मल्टीपल सेपरेट एरियाज विद स्कैटर्ड हेमरेजेस. तो इसका राइट आंसर है पेरीवैस्कुलर फ्लफी वाइट लीजन्स के जैसे दिखता है ये. So the question 3 is, what is the recommended treatment approach for patient with peripheral non-sight threatening CMV retinitis. इसमें हमारी ट्रीटमेंट अप्रोच क्या होनी चाहिए. ऑप्शन ए, कॉम्बिनेशन विद सिस्टमिक एंड इंट्रावेट्रल थेरेपी. ऑप्शन बी, सिस्टमिक थेरेपी अलोन. ऑप्शन सी, इंट्रावेट्रल थेरेपी अलोन. और ऑप्शन डी, ऑब्जर्वेशन विदाउट ट्रीटमेंट. So the correct answer is option B, systemic therapy alone. जी.
डॉक्टर धर्मपाल जी, आई होप आपके यहाँ क्वेश्चंस का आंसर्स मिल गया हो, और कुछ आप इंटरेक्शन देना चाहें, बताना चाहें तो यू कैन प्लीज आस्क. और कोई आपको ऑप्थाल HIV में और जो कोई दिक्कत हो वो क्वेश्चन भी आप पूछ सकते हैं. पर रिगार्डिंग दिस केस आप कुछ कहना चाहेंगे, और यू गॉट क्लैरिटी.
Sir explained in a very clear cut way, and now I understood what are the problems before giving the treatment and seeing the ATT treatment and also the heart treatment. So it is now clearly understood. There is no more questions. He has explained very clearly, and I understood very better, because sometimes our people will start immediately heart, but now we have to have some patience before deciding starting the heart. That's why now I understood very clearly.
Thank you, sir. I think, that was my main aim to say that before starting heart treatment, if ophthalmic examination, we should subject the patient to ophthalmic examination so that retina examination is done properly and we do not miss any lesion of CMV retinitis. CMV retinitis, if it is detected, should be promptly, thoroughly treated. Only if you find that this retinal condition has resolved, please start on hard treatment. Don't do before that, otherwise there is going to be worsening, and hard treatment will lead to increase in CD4 cell count. The immune mechanism is strengthened, and this patient is really going to have, like I pointed out, about 17 to 20% of the patients study done in India, they develop this thing, IRIS, that is immune reconstitution inflammatory syndrome, and that is again a vision threatening condition. So we have to be aware of this condition and not only think that HIV only causes CMV retinitis and acute retinal necrosis and progressive outer retinal necrosis, although they are also very important manifestations.
Sir, we are routinely doing the patient complaints any haziness of the vision. We are routinely doing this ophthalmic examination. First of all, before going into any opportunity condition, I got doubt. So it is routinely, because previously in the case presentations, one CME retinitis we presented, at that time also advised. And so we are getting a lot of information from these sessions, and we are very much thankful to Ananya madam, but Upas Nagarwal madam. So they brought good people like you, and we are learned much about our errors where we are competing. So I am very much thankful you, sir, for clear explanation. And I feel very happy. And my model officer also says thanks to you. He asked me to convey the things. He has gone examiner somewhere. So he told now he also understood before how to treat the cases.
Thank you, sir. Thank you.
He is a general medicine man.
It was really a pleasure to be part of such a nice and prestigious program where I really feel that if I've been able to convey my message, that is very satisfying for me personally. Thank you once again.
For ARTC people, doctors, the e-NISCHIT has become a oasis, sir. We are the case in discussion, it seems to be, we are in the desert somewhere, this work, that now we have learned much about it. Because of the discussion we are getting, I highly benefited. Once again, the people like you have given clear indications on how to treat another things. I am very much thankful, sir.
With permission of our expert today and Dr. Ananya, I would like to add something in it. Sir, पहले
Yes, please.
रिक्वेस्ट करूंगी अगर किसी का माइक ऑन है तो प्लीज उसे म्यूट कर लें। जैसे कि हमारी गाइडलाइन नाको गाइडलाइन एडवाइस करती है कि बेस लाइन के टाइम पर ही आपको CD4 भी करना होता है, तो इस केस में मैंने देखा कि जो हमारा फर्स्ट CD4 हुआ है वो रजिस्ट्रेशन के 4 महीने बाद हुआ है, जनवरी में। जैसे कि सर ने बताया और हमारा अभी क्वेश्चंस में MCQs में फर्स्ट क्वेश्चन था कि CMV रेटिनाइटिस कब अकर होता है, जबकि हमारा CD4 लेस देन 50 हो। तो इसके लिए आई रिक्वेस्ट आर ऑल मेडिकल ऑफिसर्स एंड सीनियर मेडिकल ऑफिसर्स कि जब वो बेसलाइन करा रहे हैं सो प्लीज टेक केयर ऑफ दैट कि वो बेसलाइन पे भी आपका CD4 हो जाए, so that you can be in a better position to make decisions कि आपको किस चीज के लिए आगे एग्जामिन करना है और फॉलो अप करना है। जी थैंक यू
डॉक्टर ज्योति, बहुत वैलिड पॉइंट बोला आपने। एंड जैसा कि आज के सेशन में मतलब जैसा कि डॉक्टर धर्मपाल जी ने कहा कि इट्स बिकम अ ओएसिस एंड इट्स बिकम अ नॉलेज बैंक फॉर ऑल ऑफ अस। तो ये सारी चीजें टेक्स्ट बुक से नहीं आती, बट द वे सर एक्सप्लेन्ड अस टू थिंक ऑफ द राइट डिफरेंशियल डायग्नोसिस एंड टू गेट क्लैरिटी ऑन द बेसिक्स, बिकॉज अनलेस अंटिल वी डोंट नो कि हम किस डायरेक्शन में सोचना है, तो दैट वी कैन नोबडी, none of us can get it from just reading book or reading from Google. So this only a true and a respectable teacher like him only could have taught us. So we are very, very thankful to Bhalla sir. And because these sessions are going to remain in our YouTube channel, so it's not that कि आपने अगर 1 घंटे में आपको जितना समझ आया उतना ही समझना है. You can always go back whenever you have some opthal case in your HIV clinic. You can always go back to these points कि विट्राइटिस ऑप्थेल की फाइंडिंग्स जो प्रिस्क्रिप्शन में आई है उसमें विट्राइटिस लिखा है तो टीबी के अगेंस्ट है या फॉर है, तो ऐसे छोटे छोटे पॉइंट से little things add up to your knowledge, so then we always a better doctor the next day. So I'm very, very thankful to both our case presenter and our expert today, Dr. Bhalla sir. Thank you so much sir for such an excellent session.
थैंक यू सर फॉर द एक्सलेंट सेक्शन. आई एम श्योर कि हमारे जो भी ART स्टाफ हैं वो डेफिनेटली दे विल बी बेनिफिटेड विद दिस सेशन, और वो आगे के लिए इसको अपना डायरेक्शन मान करके चलेंगे और फॉलो करेंगे. आई थैंक आवर केस प्रेजेंटर डॉक्टर धर्मपाल, जो कि हमेशा हमारे लिए बहुत ही इंटरेस्टिंग केसेस लेकर आते हैं, जिससे कि क्रॉस लर्निंग हो सकती है, बाकी लोग भी अवेयर होते हैं जब डिस्कशंस होते हैं. तो I thank Dr. Ananya to moderate the session, and I thank all our participants who joined today. I thank my team who work behind the curtain. Thank you all. Thank you so much.
Thank you. We can close the session. Thank you.
Thank you, sir.
Yeah, thank you once again. Thank you.
Yes.